I am here with Dr. Jason Chen, who teaches bioethics at Ohio State University. Hi, Dr. Chen. Thanks for joining us.
Hi.
So, in medical situations, hospitals or clinics, people are dying, people need things. Should the patient's age matter?
Yeah, that's a great question. In general, age is not the most important thing that you look at, right? Age becomes more relevant if we're talking about a person's clinical status, okay? But I think the more interesting question is what you do in cases of medical resource scarcity, and there are multiple patients who are clinically comparable, right? And this was an issue that was brought up at the beginning of COVID because we weren't prepared for COVID and there weren't enough ventilators. So you would have situations where you would have to, prioritize one patient over another. Now, it was generally agreed that a person's clinical condition would be the determinant of that. Okay, but what if you had two patients who were clinically comparable and only one ventilator, right? So then the question was what we should use as a tiebreaker. Right. So that's kind of like the context of the question. And some people, including me, defended using age as a tiebreaker. Okay. And the reason is because death is worse for the younger. And that's generally, I believe that is the case. And the reason why is based off of deprivationism. And deprivationism says that death is bad for you because, and to the extent that it deprives you of future well-being. And since young people generally will live longer, if they were to die, they would be deprived of more future well-being. Hence, death would be worse for them. Hence, you should prioritize them, all else equal.
Okay, so here's the idea that death is worse for young people than it is for old people. So when I ask you this question, should we consider age when deciding who to save? You want to say in general, no, but if all things are equal, then age should be the tiebreaker. Okay,
Yeah.
so help me understand how I can be a consistent, rational thinker if I believe that we should prioritize young people, but I also think that every human being is equally intrinsically valuable. So I want you to help me understand this, but also, can you first explain what it would even mean for this side to be
Yeah.
true?
Yeah. So I think a good way to understand that claim is to kind of understand what it's trying to combat, right? So the fear is that when you prioritize certain people over others, you're doing so because you deem them to be more valuable. You deem them to be more important than other people. So for instance, the fear is that, okay, well, you're saying that we should prioritize younger people. Is that because you think old people are just less valuable to society? Because old people, for instance, don't contribute economically, right? They're retired, and perhaps anything they take more resources than they provide back at that time of their life because old people will tend to be sicker, right? So they use up more medical resources. Is that what you're saying, right? And the response to that is no, right? That's not what we're saying. We're not prioritizing younger people because we think younger people are somehow worth more or more valuable to society or to the planet. We're prioritizing younger people because death would be worse for them.
So I think I want to slow us down a little bit
Sure.
before we deal with this. What would it even mean to say that all humans are intrinsically equally valuable, but then under certain situations we can use age and future well-being to
Mhm.
prioritize saving some people, younger people, as opposed to some people, older people?
Mhm. Yeah. So I would say that a good understanding of the claim that everybody is intrinsically valuable is that just in virtue of you being a living human being, you have a certain amount of value. And that certain amount of value is not more or less than any other human being that's out there. So if there's no reason to discriminate between you, then there would be no, there should be no discrimination.
What if someone wants to be discriminated against? What if an older person says, okay, you've got one ventilator, give it to the other guy? Or what if the younger person wants to say, you've got one ventilator, give it to the older guy? I wonder about
Mm-hmm.
scenarios. You
Oh,
sent me some scenario. Well, do you want to speak to this
yeah,
first?
yeah. Let me speak to that first. So that was actually a suggestion that was proposed as a way to kind of get around the difficulty of coming up with justifiable tiebreakers, right? So patients who have decision-making capacity can refuse life-saving care. That is a right. Okay. So one good strategy is to ask patients before they get, critically ill is, look, would you want to be on a ventilator? Right? It's if they say no, then that's fine. Then you avoid the issue of having to use a tiebreaker. And if the younger person says no, that's fine. You respect their wishes as well.
I've heard of something called like do not resuscitate. Is that what we're talking about here or something else?
No, that's something different. Do not resuscitate is a specific order that it's expressed, right, as patients wish, that they do not want to be resuscitated if their like heart stops. That's something different, but it falls under the general idea of respecting patient autonomy.
Mm, beautiful. Okay, I want to give you some cases that I found in some of your work and ask you to just explain what you think.
Sure.
So, this first scenario is that there's a 24-year-old woman who is dying of cancer, and she, I guess, voluntarily ingests a whole bottle of opioids, I guess, to die. And at the hospital, she's asking the doctors or medical professionals not to save her. What do you think is the ethical thing for us to do here?
Yeah, good question. So just to give a little context, I was actually the ethics consultant on that particular case. So the the husband found the patient in bed next to the bottle of opioids, and he couldn't determine how many pills she swallowed though. Okay, so they call the ambulance. She gets brought to the hospital, to the emergency department, and she tells the emergency department doctor not to save her life, basically not to give her Narcan, which would reverse the overdose, right? And it was that doctor who called me. Okay, and he wasn't entirely sure if she needed Narcan because again he wasn't sure if she had swallowed enough pills. Okay, so it was kind of like, what if she does need Narcan? Like what should I do in this case? So my advice to that doctor was that you ought to save the patient's life. Okay. Now, cases like these are difficult because there appears to be a conflict of values. Okay. A conflict of maybe what you call like the basic principles of biomedical ethics. So there are four principles of biomedical ethics. The first is respect for autonomy, right? The second is beneficence. The third is non-maleficence. And the fourth is justice. Okay. And when all of those four things align, there is no problem, usually, right? But when they conflict, that's the reason why you call for an ethics consult. It's like, okay, well, if I respect her wishes, if she tells me not to save her life and let her die, well, we generally think that death is bad for the person who dies. Generally, we think that's the case, right? So it appears that there may be a conflict between the patient's respecting the patient's autonomy and beneficence and non-maleficence. Beneficence is a duty to help others, and non-maleficence means not to harm others. So they're both about well-being, and I kind of see them as two sides of the same coin. So this scenario is a conflict of those two things, right? It's like, well, generally, I'm a doctor. I'm trained and educated to save lives, to treat the ill, but this person is telling me that she wants to die, and she is telling me not to save her life, right? So that conflict is the ethical issue here. Now, I told him to save the patient's life. Why? Okay. So if you look at the data on attempted suicides, most people who attempt suicide do not reattempt. Okay, that's one thing. The other thing is that most suicide attempts are done impulsively. They are not well thought out and well planned out. I believe that it was people spend less than 5 minutes thinking about it before the attempt. Okay,
Wow.
so most don't reattempt, and it's impulsive. That tells me that most people who attempt suicide really don't want to die, right? So for this, the principle of respecting patient autonomy, yes, that is absolutely true. We want to honor patients' wishes, but it has to be what they really want. And that is what is in question, and which I doubt in these cases when you look at the data. So I think more likely than not, she really did not want to die. And that is why it is justified to save her life. Now, I don't know this patient, right? I don't know the history. The doctor probably doesn't even know all the information there is to know about her. Okay. I'm not saying that death can never be the right decision for someone. I'm not saying that. Okay. But I'm saying that if you are placed in that position where this patient arrives in the emergency department, you know that she's dying of cancer because she's was being treated at that same hospital system, right? But given the data, it's justifiable to save her life.
Okay, beautiful. So I think I can extrapolate some things you said. It sounds like you're not, in theory, against voluntary active euthanasia.
So
Sometime, okay, tell me more.
yeah, so I kind of want to specify that, right? So I'm not speaking to anything about euthanasia per se. I'm just saying that I am not against. I'm not saying that it's impossible for death to be good for someone and for that to be a rational decision. So I'm more speaking to something like suicide than I am for euthanasia. So euthanasia is when the doctor directly kills the patient, right? And then there's physician assisted suicide, which is the doctor prescribes some lethal medication to the patient, and then the patient takes the pill themselves. That
Hmm.
would be physician assisted suicide. But yeah, so I'm not necessarily speaking on those particular issues. I'm just saying as a whole, I'm not saying that it's impossible for death to be good for someone and for it to be rational for that person to choose.
Okay, excellent. So that was peripheral, and I wanted to bring it to the center and have you speak to it. Thank you. Anything we should say about that case before we move on?
No, I think we can move on.
Excellent. So here's another scenario. Imagine that there's a 50-year-old woman who is at the hospital refusing to be discharged to a skilled nursing facility because she wants to go home.
Yeah.
The clinical team says she has mobility problems, she'll need assistance, she shouldn't be going home. The patient
Mhm.
states that she will be fine at home, she can do things enough on her own. When the medical professionals ask for her to demonstrate that she can just go to the bathroom, she literally can't. And when we figure out what needs to be done with her, we end up needing to call you, a bioethicist, to help us figure out what we should do. What do you think we should do in this case?
Yeah. So this is another case that I worked on. One of the common positions that a lot of patients have is that they don't want to go to skilled nursing facilities, which we call SNFs. Okay. A lot of patients don't want to go to SNFs. Okay. They hear horror stories. I've heard horror stories. They know of friends or family members who have been at SNFs and have just had terrible experiences. So they're like, I'm not going to go. I'm not going to go to SNF. I want to go home. And then the team is like, yeah, but you need help and you don't have, and they're like, no, I'm not going to go to SNF. I want to go home. Right. And they're quite adamant. So now seems like an impasse. It's like, well, we're saying that we are medically recommending this, but you are refusing. So we kind of go back to a point that I made earlier. Patients do have the right to refuse care, right? They have the right to refuse medical advice. They can actually leave against medical advice. Okay. That's called leaving AMA. Now, in order for you to do this, you have to possess decision-making capacity. Okay. And this is a technical term, and this is a really important one. Decision-making capacity is made up of four subcapacities. The first one is understanding. So you have to understand what the information being conveyed to you is. The second is appreciation. You have to appreciate the circumstances that you're in. The third is reasoning. So you have to be able to weigh the pros and cons of different treatment options. including the option of non-treatment. Okay. And the fourth one is communication. You have to be able to communicate. So if you possess those four subcapacities, then you possess decision-making capacity. If you lack one of them, then you lack decision-making capacity. Okay. Now, the reason why this is so important is because your rights hinge on that fact. You can refuse as long as you have decision-making capacity, right? We have to honor your decision if you have decision-making capacity. Now, that was the question here for this particular patient. Does she really understand her, like the situation that she's in? Can she appreciate her circumstances? Yeah. Yes.
So if one of
And
these four is missing, then it doesn't count as decision-making capacity?
yep, you have to possess all four.
Okay.
So when we went to talk to her, she just reiterated what she said before. It's like, I don't want to go. I'm going to go home. She did say that she had like some people living with her, but she admitted that it wasn't enough. I think she had some other helper. It might have been a family member, but the family member wasn't strong enough to lift her, right? So she was too heavy. And it's like, okay, well that means you need at least two people. And she's like, well, I don't have that many people. And it's like, okay, well, how are you going to get to the bathroom? And she's like, I will get to the bathroom fine. And she's like, okay, well, can you show us? Show us right, walk to the bathroom right now. And she's like, I can't do it. And I'm like, well, what makes you think that you'll be able to do it at home? She's like, I don't know. I'll do it. I'll be fine. Right. So a lot of patients will do that if and that tells me that they lack appreciation of the circumstances. Okay. So they say, if we say, look, like, this is why we're concerned. And they say, I'll be fine. It's not a problem. But then they can't really give us an explanation for why it would be fine. They're just saying that they'll be fine.
So what
Right.
did you think? What happened? What did you suggest?
Yeah. So in cases like when we deemed it a lack of decision making. Well, okay, wait. Let me clarify that. Only a physician can deem some patient to lack decision making capacity. Okay. And usually it's going to be the person who's treating the patient, or maybe they ask for a psychiatrist to come meet with the patient, and then the psychiatrist can say and deem a patient to lack capacity. But me, since I'm not a physician, I don't have that power. I can just give my opinion, right? And clinical ethicists who are not doctors, they can only give their opinion. So it was me and then my attending. We deemed her to lack decision-making capacity because she lacked the appreciation subcapacity. So in those cases, when a patient can't make decisions for themselves, the next step is to contact the surrogate, right? So the surrogate is the person who makes medical decisions for the patient when the patient lacks decision-making capacity, right? And then you work with a surrogate, and then you make medical decisions in conjunction with the surrogate. So that's why it's so important, right? And that's why I said your rights hinge on whether or not you have decision-making capacity. Once you don't, we talk to somebody else.
Okay, I'm ready to move on to a different case. Are you?
Yep.
Okay, I
Let's
want to
do
hear
it.
your professional ethical view on this case. A 50-year-old man with intellectual disability has been intermittently refusing routine dialysis. Sometimes when he refuses, he gets physical with the staff, and this has resulted in him getting kicked out of the dialysis facilities. And now he has to go to hospitals for routine dialysis. His son, who is his guardian, says his father is too young to die, so he wants someone to force his father to go through dialysis. The patient says he does not want to live like this. And so I'm assuming the patient doesn't want dialysis, but the patient's son is trying to get everyone to make his dad get on dialysis. What happens in this kind of case?
Yeah. Okay. So let me give you a little more context. This patient was living in some sort of assisted living facility, and this patient would go back and forth, to the hospital and then back to the assisted living facility, to get routine dialysis because he had some intellectual problem that caused him behavioral issues, and sometimes he would actually get physical with staff, which caused him to be kicked out of all the dialysis facilities in the area. And so he was the last resort was to get dialysis at the hospital. So another clarification is that a patient's guardian is their surrogate, okay? But a guardian is a surrogate that's appointed by the court, okay? And a guardian of all the different types of surrogates, the guardians have the most power. Okay. And usually get a guardian because you have some sort of long-term intellectual disabilities. So the patient, won't and didn't have capacity for a very long time. So this patient needed like somebody there to make decisions for them. And so the guardian was the son. Okay. And yeah, the patient would intermittently refuse because he's just like, I don't want to do it anymore. I'm tired of this life, right? Because when you get routine dialysis, it's like 3 times a week. It's about 3 times a week. And he just didn't want to do it anymore, you know? But we, and from the hospital's perspective, we don't like forcing people to do stuff they don't want, right? We just generally don't, even if they don't possess decision-making capacity, the fact that they don't want it has value. And we want all else equal to respect people's wishes. Just like all else equal, you want to honor the wishes of a child, even though the child doesn't have the authority to make their own decisions, right? So, we'll talk to the guardian. The guardian's like, no, just force it onto him. He can't make his own decisions. I'm the guardian. I have the authority, and I'm telling you to force it onto him. Okay. And so, in this situation, you're like, yeah, but like we just feel bad doing it. He's like refusing and stuff. Because when you force somebody, I mean, you have to physically force somebody, right? You don't want to physically restrain somebody unless you really, really had to, right? And dialysis, it's an ongoing thing, right? Where you're just gonna like keep doing that for the rest of his life, you know? And so they called a family meeting, and the patient was there, the guardian, the son was there, and then there were different members of the medical team. And the guardian was just very domineering, just talking down to his own dad, right? Just like, stop it. Stop it. You need dialysis. Okay. Stop it. And it was very disturbing. It was very disturbing. So the role of the surrogate is twofold. The first job of the surrogate is to use what's called substituted judgment. Okay. And substituted judgment means that like what would the patient want? So if you're making decisions based on substituted judgment, you're telling the team what the patient would want if the patient could make decisions for themselves, right? Oftentimes it's based off of previously stated wishes. Dad said that he would never want to be on life support or something like that. Okay. Now, if you don't know what the patient would want, then you use what's called the best interest standard, which means that you have to make decisions based on what you think is good for the patient, right? So it's a well-being judgment that you're making. First is substituted judgment, and then second, it's best interest standard. The patient was not using a substituted judgment. So the question is like, okay, well, is the surrogate, is the guardian acting in the best interest of the patient, right? It's like, well, you definitely need dialysis to live. 50 is pretty young, right? You have a lot of years ahead of you. But at the same time, I mean, are we really going to restrain this guy? Like every week, like depending on how, agreeable he is that day, right? Like, so our general position is that we do not recommend restraining somebody as a long-term solution. We recommend that as a possible short-term solution, as a bridge to something more permanent. Okay. So sometimes when somebody refuses dialysis it's sometimes when somebody needs dialysis, it can actually affect their cognitive functioning. And then after they get dialysis, they actually, they become more agreeable and more rational and stuff like that. I don't think that was the case for this person because he had some other underlying issue, but that would be another instance where we would justify restraining somebody on a short-term basis, kind of like a short-term trial. So basically, we came to an agreement and we said like, okay, let's see how he feels that particular day because he was intermittently refusing, right? So sometimes he'd be okay with it, right? So when he comes, he arrives at the hospital. Let's just check his labs, see if he really needs dialysis. If he doesn't really need it and he's refusing, send him back to the home and then bring him back tomorrow or the next day, right? Or the next appointment. And then let's try it again. Okay. So that was kind of like one of the things that we agreed on. But we also clarified that we will not restrain somebody as a long-term solution.
So right now we've been talking about surrogates and their roles in this particular case of what to do with the 50-year-old man.
Yeah.
We've covered a lot of ground. Before we end here, is there anything that we haven't discussed that you just want to quickly work in before we end?
I know, but I do want to clarify something. So it's not surrogate versus guardian, right? A guardian is a type of surrogate. So surrogate is the umbrella term, and guardian falls underneath it. right? And guardian is kind of like the highest, most powerful surrogate that a person can have because they're appointed by the court, right? So at least for Ohio, we have kind of like a list of people with the descending order of priority that we use to determine who the surrogate is. Number one is guardian. Okay. The second one is a healthcare power of attorney. And this is probably the point I want to make because I think this is extremely important for people. Okay. If you don't name somebody, a healthcare power of attorney is a surrogate that you as an individual name, right? You say, I want this person to make medical decisions for me in the case that I cannot make decisions for myself. Okay. And it is a form that you sign and fill out, right? Now, the reason why I think this is so important is because a lot of issues that arrive at the hospital is because we don't know who the surrogate is, or there is a conflict between the surrogates, right? Because it goes guardian, healthcare power of attorney, and then it goes to your spouse, right? And then it goes to you, the majority of your adult kids. And then it goes to your parents, and then it goes to your siblings, right? So sometimes there are cases where there are multiple surrogates and they have equal power and they disagree, right? That nobody wants to deal with that, right? It is much easier if the hospital knows who your surrogate is, and the clearest way to do that is to name somebody as your healthcare power of attorney. Okay, your health now just because you're married doesn't mean that you shouldn't do this. Okay, because normally your spouse is going to be your surrogate in under normal circumstances. However, there are times where you are separated from your spouse and you, for some reason, maybe you don't trust them, you don't want them to make decisions for you. You really need to sign a healthcare power of attorney form.
Great thing to add, Dr. Jason Chen. Thank you so much.